A warm welcome to all of you to this ENETS-INCA Net Cancer Day educational webinar. I'm very happy that we have this collaborative event from ENETS-INCA. Next slide, please. It's also my great pleasure to co-moderate this webinar together with Catherine Bouvier, who's the current INCA president and located at London, UK. Myself, I'm the current ENETS chair and working in Bavaria in a little town called Erlangen. Today is really a very special event because this is the World Net Cancer Day that had been inaugurated by INCA. And Casey will talk a little bit more about that in a few seconds. This is an event always held on the 10th of November and is created to increase the awareness in this rare type of neuroendocrine tumors and to provide a voice to the NET community, but also to enhance knowledge, collaboration and research in this type of tumor. So it's about drawing the attention to this disease for earlier diagnosis, but also to improve access to healthcare resources globally. With the next slide, I would like to introduce our speakers, and I also would like to thank Christos Tumpanakis, who is our advisory board chairman at ENETS, who was also involved to pulling together this program. And I'm also grateful to our faculty who was willing to prepare the talks that are patient-centered. And I would like to start with Gregory Kaltsas, who will be presenting in the first part of this webinar, where we altogether have 4 parts. And Gregory Kaltsas is a senior endocrinologist at the University of Essex. Then we have Staffan Welin, who is senior oncologist leading the NET Center at Uppsala University. And we have our 2 ladies here involved, Angela Lamarca, working at NHS Foundation Trust, United Kingdom, as a medical oncologist in Manchester, and Simona Glasberg, a senior endocrinologist from Hadassah University Medical Center. Next slide, please. In the third part of today's meeting, we will have Enrique Grande speaking from MD Anderson Cancer Center in Madrid, who is also a senior medical oncologist, and Anja Rinke is from Germany, from Marburg University, who is a gastroenterologist, who will also speak in this session. Finally, we have 2 other speakers. Next slide, please. 4 other speakers, and this is Sally Jenkins from United Kingdom, who is a patient. And we have Nieveen van Dijkum, who is a surgeon in Amsterdam University, and also Wanda Geilvoet from Netherlands, Erasmus University, who will speak for the nurses, and a dietitian from Denmark, who's Mette Borre, who will then also speak about her experience. So altogether, it's a very nice program. We hope for a lot of interaction. This format should provide you to submit your questions. Next slide, please. This is just the overview of our 4 parts. And next slide. After each session, we have a question and answer session. You are connected to us via my ENETS. You can submit your question after each talk, and we will pick these questions and answer these all together with the participants. At the end, you can provide your feedback via a survey, and that will be very helpful for us for future meetings. Thanks so much for participating. And I'll give the word to Casey Bouvier.
Thanks, Marianne. Well, yeah, as you know, as Marianne said, today is World Neuroendocrine Cancer Day, and I think it's the 12th one. Could be the 11th, but I think it's the 12th. And I'm privileged to have been present when this special day was planned. And in those years, those past sort of 11 or 12 years, I think there have been many changes in the neuroendocrine world. I think we have seen some significant and positive developments in the understanding of the disease, in diagnostic tools, in treatments, and in research. But I also know, despite all that we now know, there are still many things that we don't. And there are some facts that have remained relatively constant, I think, especially that of late and misdiagnosis, which is experienced by so many. However, saying that, I know that this is a focus for many in our community, and I have great faith that we will change those facts. I would just like to take this opportunity to give a shout out really to every organisation and individual or group that has been involved today, and who are running events all around the globe, or really just being really active campaigners, potentially on social media. It's amazing work. Being a cancer advocate can be a positive and very empowering experience, but it is also quite daunting. It's time consuming, and it does require a lot of patience. I think changes to our healthcare system take time. Validation and acceptance also takes time. But the extensive work being done across the globe by advocates with policy groups, with politicians, with lobbying groups, with commissioners, medical societies, and wider healthcare professionals with limited knowledge of neuroendocrine cancers is a testament, I think, to the growth and the maturity of the advocacy movement. And also the level of support services being offered is inspiring. And I certainly, from our perspective, we want to be seen as a complementary service to our healthcare service or our healthcare system. And there are also amazing educational and research campaigns that are running now that really will change lives. However, today is a day when we come together in solidarity to raise awareness by whatever means necessary. It is a day to focus all our attention on awareness and to support those affected by this complex disease. And I think it's important to say that it's a day that's far from being about brands, whatever brands that we all use and images that really are just symbols of our cause. Today is about collaboration and it's about unity. And I'm really delighted that ENETS-INCA have come together to highlight that collaborative spirit on November the 10th, 2021. And I do hope this is one of many collaborations. So thank you to ENETS. So in terms of the format, I know Marianne has just run through that. We do have 4 sessions today over 2 hours. As she also stated, there will be time for questions, so please utilise that time, but I am really aware that we do have limited time, so not all questions will be able to be answered in this particular session, but I do have the promise that any question asked will be answered post-event, so your questions certainly won't go to waste. So without any further delay, I think we should move straight on to part 1, and let me introduce you to our first speakers, which is Gregory Kaltsas from Greece and Staffan Welin from Sweden, who are going to be talking about the facts of incidence and prevalence of neuroendocrine neoplasms globally. Thank you both. The floor is yours.
Thank you so much, and I'm pleased to be here to hold a lecture together with Gregory, and we'll talk about incidence and prevalence, and we can take the first slide, please. Neuroendocrine tumors are a very diverse group of neoplasm, and you can find neuroendocrine cells almost in every part of the body, and therefore tumors can arise from every part of the body. The most common is the GI tract, the pancreas and the lungs, but in neuroendocrine tumors also medullary thyroid cancers, adrenal medulla, pheochromocytomas, paragangliomas are included. Among pancreatic NETs, there's a lot of different tumors such as carcinoma, insulinoma, and so forth. Next slide, please. From the biggest data set from the SEER database, there's a lot of 35,000 tumors. We can see the incidence in different tumor types, and the most common is the GI, followed by the lung and thymus. And among the GI, the most common is probably the mid-gut and the hindgut tumors. Next slide, please. The incidence has been increased, at least as we have what we can see. And you can see different type of neuroendocrine tumors, and this is figures from 1973 until 2003. And you can see that especially the lung nets, the small intestinal nets and the rectal nets are increasing a lot. Next slide, please. So we are now going through, and what is the reason for, if there is a true increase in incidence, if there are differences in race, sex, or other certain areas. And we'll go through this, and I will give some questions to my colleague, and he will have a short talk about the different things. Next slide, please. So, is it true that the net incidence is increasing?
Thank you very much, Staffan. It's really a pleasure to join and participate in this webinar with you and share the experience. And just if we can go just to the previous slide, because I want to clarify some terms. Previous slide, please. It's very important to be sure that we do know that there is an increase in the incidence of these neoplasms, and but we're not sure if this is a true increase or it's a consequence of the investigations that have been undertaken. But before proceeding further to try and reply to the questions that Staffan will ask me in order to clarify all the particular events that may have a consequence in the increase in these neoplasms, we have to define some terms. So I just want to clarify that when we're talking about incidence, we are talking about the number of new cases of a specific disease, particularly the one that we're facing or dealing today, that they occur during a certain period of time in a well-defined population. Whereas when we're talking about prevalence, we discuss the number of cases in a population over a certain period of time. So this means all the cases where the incidence is the new cases during that period of time. And having said that, it's important to know about the survival rate, which is always a very important issue, and we'll say a few things about that later on, and the overall prognosis. So can I have the next slide, please? So in order to reply to the question that it was put to me by Staffan, as you can see from this graph, in the left side of the slide, you can see all the gastrointestinal neoplasms that they have been stable through the period of time. And this is the most updated version of the SEER database, where you can see on the ones that they are derived from the gastrointestinal system, they are increasing dramatically. And you can see that there's a 6-fold increase. And this increase is world over. You can see it's more prominent in Ireland and Canada as well, but in other parts of Europe. And can I have the next slide, please? So we also have to account if there is a specific reason for this, and if this is a real increase in incidence or if there is an incidental finding. But as you can see, if you look at the lower part of the slide, you can see that a bright spot in the pancreas, which shows that these neoplasms have increased 4-fold during the last years. So it's probably the question if it's related to the more sophisticated methods that we use in order to try and reveal these neoplasms. And if this was the case, then you would expect that you're going to have more findings in more accessible tissues, like the stomach with endoscopy, or the bowel with the colonoscopies. We do now screening and surveillance endoscopies. And but this is not actually always the case, because there is an increment, as you can see on the right side of the slide, and you can see the colors. There is an increase in all the neuroendocrine tumors, but you can see an increase in the rectum ones, and which is the second line, and then there is always an increase in the small intestine ones, which is the third line. So this is not clear why this has happened, and there is a prospective study when they looked at all the neoplasms that they were found in Austria during a period of time, and they found the most common one was the stomach. So there were some questions related to some factors that they could be implicated, like the use of very commonly used medications like the proton pump inhibitors for stomach upset and ulcer, and these questions have not been resolved as yet. Next slide.
So we are now going through some specific characteristics of NET, and if there are any differences in sex, race, tissue, organ, extent of disease, aggressive behavior, and effect of prognosis. So, are there any differences in between sexes?
Next slide, please. Yeah, this is a self-explanatory slide, and you can see from the graph, both sexes have the same kind of increase. So we can say that more or less the increase in incidence in these neoplasms is equal to both sexes.
Okay, and regarding according to race, next slide, please.
Next slide, please. So as you can see from this graph, and you can see that different colors represent the different races, and it's obvious that there is an increment in all races, and I hope you can see the colors. The ones that are on the top are the ones that originate from the African Americans, which seems to be the most prominent increment. So this particular race has the highest increase in the incidence of the neoplasms, although the increase is obvious in white population and in Asian populations. Next slide, please.
Okay, is there any differences in tumor, where the tumor arises in different races?
Yes, and as you can see, the Asian populations, as I told you, the ones that they have the most prominent increase, the ones that they derive from the rectum and from the small bowel. But as you can see in the right part of the slide, the ones that originate from the Asian population, they're a little bit different, because the most common ones are the ones that they originate from the lower bowel, like the rectum ones, where the ones that they originate from the middle bowel, which is the small bowel, which is more common in the white population, is relatively rare in the Asian population. And only a small percentage of these patients have them very well known symptoms of the carcinoid syndrome. Next slide, please. But this is not always true, because as you notice, when there was a migration from people from China to Canada and the United States, then there was a twofold increase in the incidence of neoplasms originating from the small bowel. So it's probably a combination of genetic and environmental factors, because as I showed you previous, those that originate from the small bowel are relatively rare in Asian population.
Next slide, please. So, is there any differences in site of origin?
Yes, as you can see here, according to the different populations, the ones that I mentioned, there is an increase in the small intestinal neoplasm, and the ones that originate from the rectum. These are the two lines on the top of the graph, on the right side of the slide. But there is heterogeneity at different parts of the world, because there is more prominent in some races and in some populations. As previously shown the initial slide, the ones that originate from the lung, which is not the purpose of our discussion today, they're relatively common as well. So different sites have a different increment, and the ones most prominent in the white population is the small intestinal and the rectum. But as you can see, the pancreatic ones, which is the gray dot, is increasing, and this is the 7-fold increase I showed you in the initial slides.
Okay, how about stage? Is it only the local tumors that we find more often, or is it the widespread metastatic disease that are increasing?
That's a very fair question. And as you can see from the right part of the slide, there are some stages. And what we mean by that, when we say that it's localized disease, we mean that the disease or the neoplasm is in the particular tissue of origin, like the pancreas, as it shows there. If it is regional, it extends a little bit further from the pancreas, but not in other distant parts of the body, and to the lymph nodes. And this is the localized and regional disease, the stages that I show. And then if it is a distant disease, which is the stage 4, it extends further from the tissue of origin. But as you can see on the left part of the slide, the ones that they have a more substantial increase is the ones on the that they are localized disease. So we do have an increase in incidence, but the majority of the neoplasms, they are localized.
Okay, what about grade? Is it the low proliferating tumors or the high proliferating tumors that are increasing?
And this is a very interesting and very important question, because as you can see from the right part of the slide, there is the GO phase, and there is the other phase. The GO phase is when the cells are resting, but then they go to the G1, S, and G2 phases. They're multiplying. And as you can see, when they are multiplying, we can identify the cells that are multiplying by measuring in the tissue a protein which is called Ki67. And as you can see on the left part of the right part of the slide, there are very few dots, and this is called G1. When these dots are increasing, they are G2 and G3. When we go to G3, this is highly proliferating. And if you go to the left part of the slide now, you can see that the ones that they are really increasing are the gray one, which they don't multiply very, very quickly. So they have a very slow growth.
Okay. The metastatic disease, is that as common in Asia as in Europe or in America?
Next slide, please. And as you can see, there are differences in the prevalence of metastatic disease according to the different areas, regions. But the good news is that the increase in the patients in the incidence of neuroendocrine tumor is mainly based on the increase of the localized disease, because as you can see on the right part of the slide, the ones that they present with metastatic disease, they remain more or less stable during the years.
Okay. So we also had an issue about, is the prognosis, is it better if you go to a centralized hospital or a more local hospital?
And these are good news, because as you can see, the prognosis, if you look at the upper part of the slide, has substantially increased and has gone much, much better, particularly after the development of the specialized centers of caring for these patients, like the ENETS Centers of Excellence. So these are good news. Prognosis has substantially been improved over the last years. And next slide, please. And there are some take-home messages in order to finish this presentation. We showed you some data that the net incidence is increasing, but this is mainly due to localized disease of relative low growth neuroendocrine neoplasms. There are differences in the sites of origin according to regions. There's no clear if this is related to a true increase in the incidence of secondary to the detection methods used. There is an overall improvement in prognosis, and there is a need to develop specific databases and working groups in order to improve the accuracy of the information gained regarding incidence and prevalence of this disease. And thank you very much. That was the end of our presentation.
Thanks so much.
Okay. Yeah.
We do have a couple of questions that have come through that I guess we need to pick out the questions relevant to these particular parts. There was a question about stats in the UK, which I will reply to personally on that. There are statistics is the answer to that. But it was about classification and about the difference between a net and a neck.
Yes, shall I take it, Gregory?
Yeah, please.
Yeah. The classification has been changed over time and is still changing over time, I would say. But neuroendocrine tumor, which those are mostly slowly proliferating, the G1 and the G2. There are some G3 with the proliferation rate above 20% that has is called a net as well. And the tumor cells are very much alike the normal neuroendocrine cells. That's why they are well differentiated. A neck neuroendocrine carcinoma is highly proliferating, growing very fast. And if you look at the cells in the microscopy, they are very much unlike the normal cell, which make it poorly differentiated, as we also call them, and call them early in the classification. So it's very much about the aggressiveness of the tumor, I would say.
Thank you.
you have to be reassuring for the audience, because the neuroendocrine carcinomas are relatively rare tumors in this entity. They present about 10% of these neoplasms. So the good news that the ones that we're dealing with are the ones that they're well differentiated, G1, G2, and a few G3. And the good news is that the ones that they are picked up now are localized tumors, so they have the potential of having an excellent prognosis.
Thank you. There was just another question before we'll have to move on, but it was saying, why are some diagnoses referenced as unstaged?
Sometimes because unstaged, because the classification systems that they have been used, they have not been good enough, and maybe not all the investigations that there are armamentarium now to be used have been utilized. And don't forget that this is the SEER database, and the data that are inflicted in there, they're not always very, very precise. So I think that with the techniques that we have now and the availability of the new classification systems, this percentage of neoplasms becomes very, very small.
I think very nice presentations from both of you. We have a series of other questions. I think Casey should maybe pick another one. Can you display question 5 that was coming in very early? It appears this particular cancer is normally diagnosed in the later stages to the range of symptoms. Any particular symptoms the individual can look out for? I think obviously say these tumors are very indolent, we diagnose them late, and the delay in diagnosis is 5 to 6 years. But I think, Casey, you also did an analysis in the UK together with John Ramage. I think if we ask the patients clearly, they have more symptoms than that it looks like, but patients get adapted to symptoms like pain or bowel movements that may be disturbed. So the question is how do we go in depth in the communication with the patient that we discover these symptoms very early? Because if we speak to the patient, they say, oh, it started 5 years ago. Why does nobody recognize it? What is your experience, Greg and Staffan, with these symptoms, the late diagnosis, and why is it so late, and are there symptoms or not?
There are some of the symptoms are very common even among people who don't have any tumor. I think it's becoming better, and some of the increase of incidence is that we do a lot of more investigations in every country, and then we find more tumors that we perhaps wouldn't have done 20 years ago because we didn't have the availability of good radiology, for instance. But of course, it's about knowledge at the doctor who you are seeing. These are uncommon tumors still, even though the prevalence is quite high. So, but I think that every man or woman knows their body themselves, and if something's not correct, I think you have to talk for yourself to make the doctor do some investigations. And I think that the knowledge has increased immense since I started to work 25 years ago. So it is becoming better, but we still see a lot of patients waiting years to be diagnosed.
Education's the key, isn't it? And I know it's work that's happening all over the globe, as I say, with these educational programs. So we've got to keep going with that.
Oh, okay, frequent symptoms, but rare syndromes or rare diseases. So that's, we should never forget and need to teach the primary treating physicians that we do not always reach early enough. So that's something we need to improve. So Casey, we have to move on, or can we take another question?
We could do 1 minute answer on one more question. There's quite a few questions here. We will answer them post-event though, I promise. Do you want to pick one, Marianne?
So how rapid or slowly is the average progression of NET? Maybe you can elucidate that a little bit more, Greg.
As I discussed previously, these are very slow-growing tumors in the majority. So that's why some of the symptoms can be very subtle, and they are not easily recognized. So the time interval for these tumors to increase in size, in dimensions, may be years. So this is the majority of the patients, and the patients are in a really good condition, although they may have quite big load of the disease. And then there are some other, and they can go in a period of standstill. So we can see sometimes tumors that they remain stable for a considerable period of time with no treatment. So if we're not dealing with the minority, as Staffan mentioned, the ones that they're high proliferating ones, so these do not grow that quickly. And that's the good news. And this is the interesting thing, because this regarding to incidence appear to be relatively rare tumors, but the prevalence is quite high. And this is because they are slow growing, and so they remain for a long period of time. And the patients that they have a lot of disease, they do very well. And so that's the difference between incidence, which is low, and the prevalence, which is relatively high. So they do grow, but they do grow relatively slow, the majority of them.
Okay. Sorry. So we've just been given 5 more minutes, Marianne, so we can probably run through a couple more of those questions.
Oh, perfect, perfect. And please keep going to submit your questions, even if you can't. Well, that's really terrific that you are so interactive here. And there's a question. I had been diagnosed with a NET. Do I need to be worried that my children will have a higher risk of NET? There's no family history. Maybe you can highlight who would need to have a family history and genetic assessment.
I can answer that. There are, especially pancreatic NETs, are sometimes involved in genetic diseases like MEN1 or von Hippel-Lindau's disease. So if you have several, because you often get several pancreatic NETs in that case, and so if you have multiple pancreatic NETs and perhaps a high calcium with, then you might think of a genetic test for that. There are rare cases of familial small intestinal NETs, but that's very rare. There are genetic research been done, but so far we haven't found the genes for this so far. But there are very the normal is that it's not a genetic disease.
Yeah. So who would be the ideal candidate, or who would be the candidate where you would advise this patient needs to be referred to a genetician to really analyze if there is a germline mutation and risk of inheritance?
I would say multiple pancreatic NETs, I would say. And if you have a history of peptic ulcers or kidney stones at the same time, we usually draw our minds, or a very young patient with pancreatic NET, we also at least think of it and ask quite about the family history, and are more a bit more not hasty, but we take a more genetic test in those patients just not to miss them.
Yeah, and so if there's association with other endocrine malignancies, or another pituitary tumor or enlarged parathyroid glands, a young age of a patient, that all lets us think that there may be a genetic background. But as Staffan said, that's a rare event. In 90–95% of the cases, that's happily not an inherited disease. There's also a question that is not so unimportant. So which markers are available for NET or NEC?
I was just going to ask that question myself. Yeah, I think it's and it's quite pertinent to this year's kind of theme as well in our later misdiagnosis. A lot of people ask about how, you know, how can we test them? How can we see through markers, whether you've got a NET or a NEC or any diagnosis for neuroendocrine. What have we got? What tools in the armory?
We do have a biochemical marker that we use for these patients, and their diagnostic accuracy, it depends. It depends according to the load of the disease, and we use some terms in order to identify the diagnostic accuracy in like the sensitivity and the specificity. And in order to be sure that you don't misclassify patients, you have to be relatively very, very careful to see if there are any medications that they can interact with this marker. This marker is called chromogranin, and it comes out from many endocrine cells that they have the secretory ability, because pituitary tumors or tumors from the other organs can secrete this marker. So it's not the ideal screening test, because a lot of conditions can affect it. But if you think and you have a very high clinical suspicion, then you can use it, and you can use it to verify the diagnosis and monitor the disease as well if you use particular cutoffs of changes. So chromogranin A is the universal marker. There are some other markers that they may come into the future that are more sensitive to pick up the disease and more specific to differentiate this disease from other tumors, but they have not been into clinical practice as yet. So there's still things to be done regarding the biochemical markers. And
what do you measure in NEC?
As I said, this is a relatively rare event, and you use some other markers, non-neurospecific NLAs. It's a marker that you can use, although again, the specificity and the sensitivity is not great, but it's better to use this marker in the next. But hopefully these neoplasms are rare, so we have to be a little bit more pragmatic in the real prevalence of these tumors, and the increase in the incidence is the well-differentiated G1, G2. So I'm not thinking about NEC.
Okay, Staffan, you have anything to add here for the biomarkers?
For biomarkers, I think it's more common blood samples like lactate ordinary liver enzymes, for instance, and things like that, to see the cell turnover. You can also alkaline phosphatase is also a good marker, but it's a predictive marker for many diseases. So it's there are NECs that have hormone secretion, but most do not. So you shouldn't rely on chromogranin A or something like that in NECs.
Yeah, that's important. Sometimes it's simple markers like alkaline phosphatase being associated with prognosis, or LDH, lactate dehydrogenase, but it's not so 100% elevated in all NEC or highly proliferating tumors. So we, as Gregory said, and we all agree upon, we need an improvement here for biomarkers that are more sensitive.
Yeah.
Do we ever use inflammatory markers as standard, like they do in some other cancer types?
Inflammatory, can you specify what you would like to measure? CRP or?
Yeah, I think it's those kind of generalized markers that you might use in other diseases or other inflammatory issues. There's some work in other cancer types, and they're looking at using inflammatory markers that were quite high, for example, in gut cancers as well, that it's used quite a lot in order to be able to identify where the tumor might be. But I wondered whether we've ever used anything like that in the neuroendocrine world, or whether there's no relevance.
In G1 and G2, I don't think it's any relevance, because they most often have normal CRPs. I mean, you take them before you give them PRRT or chemotherapy, and they are rarely raised. In G3s and NECs, perhaps you can see that it's you have high values, but I wouldn't use it as a marker. No.
Thank you.
This is related mainly to the progress of the disease and the cytokines produced, and the performance status of the patients. And these are slowly growing neoplasms. The patients behave and they tolerate the disease for a long period of time. So it's not used that much.
Okay, so we conclude not the current values. So that was a very nice discussion. Thank you to both of you again for sharing your knowledge and for being available for this discussion. I think, Casey, we have to move on.
We do.
With the next
Thank you both.
And it's my pleasure to welcome now again Angela Lamarca from Manchester and Simona Glasberg from Hadassah, Jerusalem. And we deal now with a very important topic that is very relevant. This is a patient-reported treatment side effects, what causes side effects, and then treatments and strategies for side effect management. We are very happy to have you here, Angela and Simona, to cover that topic. Welcome, and the floor is yours.
Thank you very much, Marianne and Catherine. It's my pleasure to really be here today, and it has been my pleasure as well to prepare this presentation with Simona. So next slide, please. I'm going to go through a very short presentation, and then Simona and I will be able to answer any questions that come through the chat. So please, I encourage everyone to submit their questions. So the title that we were given is about the patient-reported treatment, as you said, and about the side effects that are associated with neuroendocrine tumor management. Next slide, please. These are my conflict of interest. Next slide. And I think the first question that we want to answer is about what are side effects, because we are always talking about side effects, and sometimes I don't think we really explain to patients what are we thinking or what are we talking about. So I went to the Wikipedia and see which type of description they were giving, and I think it's actually quite self-explanatory, and the way how they explain it is that side effects are unintended consequences of the use of a drug. So they will be complications that appear because someone is taking a specific treatment, in this case for the management of neuroendocrine tumors. Next, I think we need to also understand that we talk about side effects, but sometimes doctors, we also use other synonyms without really explaining why. So next, please, and next. When we talk about side effects, sometimes we may mention toxicities or we may talk about adverse events, but actually I think it's an important message to clarify that these are synonyms and everything are related to the same issue, an unintended effect created by the fact that someone is taking an anti-cancer treatment. Next slide, please. So why do the side effects happen? Why is it happening that when someone takes a treatment, there are some complications, or there may be some complications, where the side effects are actually the reflect of that treatment reaching not only the cancer cells, but also the healthy cells. And I think we need to understand when someone is taking a treatment to stop the growth of the cancer, usually is taking that treatment orally or by an intravenous infusion with a drip, or maybe an injection like happens with the somatostatin analogs. So the body will distribute all that treatment through the whole body. It's not only going to go to the cancer cell, it will actually also reach some of the healthy cells in our system. When the treatment reaches the cancer cells, it's going to stop the growth of the cancer cells. But when it's reaching the healthy cells, those healthy cells develop a little bit of a reaction, like protecting from that treatment. And that is what is causing the side effects. Next slide, please. Something that I think is important is sometimes the patients will ask, will I get side effects? So are side effects always going to happen? And I think, to be fully honest, most likely, every patient who is getting some form of treatment will get some form of side effects, but it will vary on the severity, and it will also vary on how many of those side effects you may get. And I will discuss that a little bit later. But I think we do need to be upfront with patients in the way that it is likely that every patient will develop some form of side effects. Sometimes they may not at all impact on the quality of life, and they may be totally tolerable, but there are still side effects. Next slide, please. So going back to the question, will I get side effects? Most likely, yes, but will I get all the side effects listed? Is very, very unlikely. So the most likely scenario is that a patient may get some of the side effects that you may get listed when a treatment is explained to you, but it's very unlikely that you will develop all of them. The reason why all the side effects are always listed is because for the regulatory agencies, it's really important that there is upfront information about what may happen. And therefore, all these lists are reporting on adverse or side effects that may be very common, happening in 1 out of 10 patients, but also very, very rare, happening in less than 1 out of 10,000 patients. It's very important that we are aware of this, and it's very important and actually good practice that when a patient is being consented for a specific treatment, we don't always explain the most frequent side effects, but we also explain some very rare but maybe important side effects that may develop. So that's the reason why the lists are usually so long, not because you are going to get all of them, but only because it's important to be informed. Next slide, please. The other question is, will all the side effects be severe? So if I get tiredness, is that going to be a very severe tiredness? If I get nausea, is that going to be very severe? And the answer is no necessarily. As I said, every patient is different, treatments are different, and actually the side effects may vary from very minor, what we call grade 1, to life-threatening, very severe, what we call grade 4. Grade 1 side effects are very, very common. Grade 4 are always less common. And it's really important that you speak with your doctor about what profile of side effects they will expect from you as an individual, because again, all this is about information and communication when a treatment is being explained to you. Next slide, please. Unexpected side effects are something important. I did mention that these regulatory agencies are asking us always to report on all the side effects, and the list is usually huge, but even with that huge list of side effects, sometimes unexpected side effects may happen. It is uncommon, but it could happen. And it's very important that these unexpected side effects are also reported. Next slide, please. This is usually done, next slide. This is usually done with what we call a yellow card. So even if there is something that you have developed while you are on a treatment that is not listed in that list of side effects, always mention it to your doctor, because it may be something unexpected that your doctor needs to escalate and needs to report. So all healthcare professionals are aware of this. Next slide, please. So the answer to, do I need to tell my doctor about all side effects? Yes, because they may be treatable, they may be manageable. Sometimes we need to give you some treatment to control them. Sometimes we need to adjust the dose of the treatment. Sometimes they may be unexpected and the doctor needs to report them. So the answer is always yes. If there is a side effect, especially affecting your quality of life or that you are concerned about, always mention it to the doctor. Also, understanding why you are developing that side effect sometimes can help with the anxiety associated to it. Next slide, please. So which side effects may a patient with neuroendocrine tumor develop when they are on treatment? Well, the answer is that this depends on 3 pillar things. The first one is about the treatment that is being administered. The second one is the performance status, which is the wording that doctors use to define how strong that patient is. And the third one are comorbidities or the general health status. So someone with other health problems may have more side effects than someone who is otherwise fit and well. Next slide, please. And based on this, we can classify treatments between easy or low risk, or challenging and very high risk. And we are usually able to predict how the patient may react to the treatment. So again, this comes down to the communication with the doctor when you are considering a treatment. And you can actually ask what type of side effects and how severe are you expecting? How challenging do you think this treatment is going to be for me? Next slide, please. I will now focus on the treatment administered next. And this is important because side effects there are a lot of different side effects, and we try to summarize in this table the main side effects that may develop. Different treatments may be associated with a different profile of side effects. Next slide. So for example, on a patient who is on treatment with somatostatin analogs, we usually consider these treatments to be well tolerated, but even if we say well tolerated, we are still expecting some patients to have a little bit of tiredness. Some patients will also develop high blood glucose because of the somatostatin analog. And if someone was diabetic, maybe the diabetes is not well controlled anymore and needs additional treatment. And also some patients develop what we call pancreatic exocrine insufficiency, which is usually characterized by diarrhea, abdominal pain, and cramps. and it may be developed after statin somatostatin analog. So these symptoms, these side effects may appear with somatostatin analogs, even if we say that they are well tolerated. Next slide. When we use targeted therapies, and the most commonly used are sunitinib or everolimus, the profile is again different, and you see that other side effects have been highlighted. Again, patients may feel tired, poor appetite, sometimes weight loss because of that tiredness and poor appetite. We also see sometimes an impact on the blood count. Usually it's not so much in the form of neutropenia, but lymphopenia with everolimus. And again, the high glucose may be developed as well. And as you see, we also have more problems in the skin side. Some patients have rash. Some patients can have sore palms and plants, or even mouth ulcers. Some patients have nausea, diarrhea, and sometimes the high blood pressure as well. Again, not everyone is going to develop all of them. Not always is going to be severe, but this may develop in different degrees. Next slide, please. When we talk about PRRT or the radionuclide therapy, the treatment effect is usually different. And in this case, as you see, we don't have many problems with the skin, sometimes a little bit of nausea. And mainly what we have is more blood-related problems. So we may have anemia or neutropenia, the low blood counts. And we also will keep a very close eye on how the kidneys are functioning, because we know that the PRRT can have that effect. And as you see, tiredness is always there, almost associated to every treatment. Next slide, please. And finally, chemotherapy. Chemotherapy is probably the one that is more likely to develop side effects. We can have tiredness, hair loss, again, nausea, vomiting, diarrhea, a lot of digestive symptoms, and sometimes skin problems as well. And again, similar to PRRT, blood-related issues as well. So as you see, the profile of side effects will vary depending on the treatment. Next slide, please. Just to summarize, I think the take-home message that Simona and I were trying really to put together with this presentation is that it's most likely that every patient will get some side effects, but the number may be tolerable and the severity may be tolerable, and it may actually not impact on your quality of life. It's unlikely that you will get all the side effects and very severe side effects, and that's the truth, or at least the most likely scenario. The type of severity changes, especially depending as well on the treatment, and always to talk to your doctor and ask whatever question you feel you won't have an answer before you start a new treatment. I think that's our last slide. Thank you. Thank you very much for your attention.
Thank you for preparing and Angela for presenting. So we have a series of questions there already. And maybe let's start with the malabsorption issues with sandostatin. How to manage this, particularly management of weight. And there's a patient having severe bile malabsorption. What do you recommend?
So if I can start, I would like first to thank very much indeed to the organizers for the kind invitation to participate. And it is really an exciting time for us, both healthcareers and patients, to come together. And I think that, as Kathy was mentioning, the collaboration is the most important key to succeed in what we are doing together. And thank you, Angela, for presenting the slides. So regarding the issue of malabsorption and the weight issues regarding to the treatment with somatostatin analogs, this is really one of the topics that we see many times in the clinic, and it has to be addressed by including many aspects, because when we have weight loss under treatment with somatostatin analogs, there can be many reasons for this. And this is, for example, highlighting the role of collaboration with a nutritionist in our multidisciplinary team when we treat our patients. Specifically, malabsorption is one of the adverse events that we see with somatostatin analogs, and it is produced practically due to diarrhea. Diarrhea in a patient with a neuroendocrine tumor can be produced by many factors. not only the treatment with somatostatin analog, but also it depends on the type of the tumor that the patient has, on the hypersecretion of different hormones, on the type of operation, if there was one previously, and of course on the type of diet that the patient has. So all these things should be, of course, very well discussed in a very much detail with the patient, and to understand when this weight loss started, if it was before the surgery or before starting the treatment or afterwards, if there are some interventions such as specific drugs or dietary changes that can help to improve or to stop the diarrhea and to stop the weight loss, etc.
What I will add to that as well is I think is really important to explain the difference between symptoms and the side effects. And this is something that came up when we were actually preparing this webinar. It's sometimes different. So symptoms are problems or diarrhea, for example, that is directly caused by the cancer itself. And the side effects, as I explained, are associated to the fact that someone is taking a treatment. They are treatment related. And the problem is sometimes doctors, we don't really know whether something, the diarrhea, for example, if it is because of the cancer, if it is the symptom, or if it is the treatment effect of something. And this question about the somatostatin analogs and the malabsorption is actually a very good example, because sometimes patients may have had diarrhea before. They may have noticed a difference in that type of diarrhea, but they don't really explain that to the patient, to the doctor. And sometimes the doctor is not really asking about whether there has been a change in the type of diarrhea. And again, this is down to communication. We do need to ask, do you have diarrhea? Yes, but how is that diarrhea? Has it changed? Because then we will have the information to know whether it's the symptom or whether it's actually the treatment change. And patients do need also to explain that to the doctor, not to be shy and just to bring up that information to us so we can work together.
Yeah, I think communication is certainly going to be a key message here. But I mean, obviously, people are going to experience different side effect profiles, even with the same treatment, which, you know, is obviously something we see a lot, especially with the use of social media, etc., where people share potentially that their side effects with each other for support reasons. But I just wondered what else we could do apart from, you know, actual facts about what side effects could occur, etc., that we can do to actually practically manage or help support somebody to practically manage their side effects, because I'm not sure we always do that so comprehensively. I mean, there are other things that we could do, you know, from communication and explanations, but also, you know, having a nurse perhaps to coordinate care, etc. So I just wondered what in your practice you would do to try and help facilitate someone manage those side effects, which may well be there and you can't stop them.
Can I start answering? So practically in the practical routine, we do involve, of course, our nurse, NET nurse, in discussion with the patient about changes in the diet, etc. But what it's important for me as a practitioner, I'm always asking if there is a change since we increase, for example, the dosage of somatostatin analog, and sometimes we consider to decrease for a while the dosage and then increase it gradually, for example, to address these side effects or the diarrhea. And also we practically discuss in terms of adding, for example, pancreatic enzyme supplements if the diarrhea is developing or deteriorating under treatment with somatostatin analogs or bile acid binding drugs that can help very much. As well as specific questions on the diet that the patient is having. If there is a high fat diet, for example, so it should be switched to a low fat diet or to what is called healthy fat diet, and so on. This is what we are doing practically, and we are very much in permanent relation or a connection with our patients. And I think one of the most important messages here is to be proactive and to ask proactively about specific side effects and if this side effect is improving. Because, for example, I hear many times, oh, I have some loose stools or some diarrhea, but I didn't think that something it can be done with it, or and to explain the patient about these possibilities of supplements, pancreatic enzyme supplements, and so on that I was just mentioning, and to explain how to take them, that you can start and increase gradually to take with each meal, and depending on the fat in the meal, on the how big the meal is, and so on. This is what we are doing actually.
Yeah, sorry, Angela.
I also think, Catherine, the role of a nurse with a specialist knowledge in neuroendocrine tumors is really crucial for what you said and for a lot of the delivery of what Simona just described. Not only having doctors who have knowledge on NET, but also nurses involved in the team. That's really important for that communication, which sometimes is more one-to-one with a nurse than with a doctor. Sometimes patients are more comfortable discussing some things with nurses.
Yeah, and I think also, how does it work in terms of, informing primary care of some of the patient's issues? Because patients may end up just having to go to their GP because they can't get hold of the team, or you might be miles away, or whatever the reason might be. That's surely got to be quite an important part of your work, so that they have someone else that's at least aware of what's going on.
Yeah, and sometimes the problem is GPs are not fully aware of what neuroendocrine tumor is, or the symptoms that they may develop, what may be relevant, what may not be relevant. So there is a lot of education to be done there as well. It's definitely a challenge.
I think also this needs to be meticulously to be sorted out, and that's best done in NET center, because the primary treating physician is not aware that maybe a pancreatic insufficiency may occur late. In some patients, it only occurs after years, and nobody is then thinking of that. There was another question here in the chat. Somebody who submitted that he has a lung NET for 6 years, treated with lanreotide, and now there is some problems occurring. And the question is really, what is the true reason behind? Yeah, now digestive issues are present and no weight loss. What is the best route forward? Change SSA, perhaps Creon? I think really it needs to be sorted out. Is it really the pancreatic insufficiency? Then, of course, we recommend the pancreatic enzyme supplementation. It can be also increase of secretion of bioactive compounds, and then that can lead to the opposite, increasing the SSA dose, or using other drugs like telotrestat ethyl for down regulation of serotonin. I think, and that is really the expert that is required here. I think I have the feeling that for the primary treating physicians, they don't know how to place it. What are the true reasons? And this needs to be really taken seriously. Sometimes I have also the feeling that patients are overwhelmed when we introduce them to the disease. We tell them the whole story. They want to know about the prognosis, how the disease will evolve. Sometimes they are accompanied by their family. Sometimes they are there alone. There are elderly patients that have not a high level of awareness or can't follow us. We try to use easy terms to explain the disease. But in the beginning, it's a lot of information to talk about the disease, the side effects, and so on. And sometimes it's good to give them leaflets. I don't know if you also do that. For example, in some more complex treatments like everolimus, SSA is a rather easy one, but may be difficult also in some patients. But we give them leaflets or brochures where they can read. Then we instruct them on preventive measures. We even involve the pharmacy. We also had a project here, Borre project, that we performed in cancer treatment in general in more than 200 patients. For all cancer types, I also included 40 NET patients. And I have maybe half an hour. Sometimes I dedicate an hour for a patient if the patient is first time with me and needs to know everything. But it's also depending on the capability of the patient to deal with all this information at a one-site visit. So sometimes it's good to have a connection to the pharmacy if you have these services available, or the nurse practitioner, that they can follow up with the patient. We have to be aware of interactions with other drugs. And the more issues are there, the more diseases. And that's another question here from the audience, how to deal with multiple issues and other diseases and the ethnic origin. And maybe you can also elucidate on that. In some patients that have comorbidities, it gets more and more complex. So this is one consultation day that can't be managed. So how do we do that best to accompany the patient and to avoid side effects? Maybe you can both comment on this. Multiple issues, comorbidities, and ethnic origin and tolerability of drugs.
Yes, thank you, Marianne, for highlighting the complexity of the treatment of neuroendocrine tumor patients. And indeed, when there are comorbidities, it's even making this even more complex, because as you said, we have specific time for a patient, and always we take the time if needed to explain more and to address more each of these parts in the treatment. However, I think that this is the place also not only to consider and to look by ourselves to possible reasons for drug interactions and side effects and so on, but also to work as a team with collaborating. For example, if a patient has uncontrolled diabetes and I have to start somatostatin analog or to start everolimus, for example, that both can deteriorate the status of the diabetes. So by myself and together with the help of our nurse in the unit, but also in our center with the unit for the diabetes treatment, we should approach this patient and explain about, increase the dosage of the treatment for the anti-diabetic treatment, and put him or her in a direct connection with the diabetic nurse, not only by the NET nurse, but also with the diabetic team, the dietitian from the diabetic clinic, and so on. And the same, for example, if the patient has hypertension and uncontrolled or heart disease on the background. So it is not easy to decide, and these decisions on treatment and changes in the treatment or in the treatment dosages, we are making them after a very, very deep consideration of all these possible comorbidities and so on.
Yeah. And I think it highlights just in a comment that's come up on the screen as well here, that sometimes you're given treatment for side effects of another treatment, and what are the adverse effects of having all of these treatments, and that's something that I know that does concern people in terms of long-term adverse effects of multiple treatments to support side effects of other treatments, etc., and of course comorbidities. So I think that's something that I'm not sure what work is going on looking at long-term side effects of multiple treatments like this. I don't, Angela, if you have any comments on that.
What I will say about that, Catherine, is that usually, as a general rule, for the treatments that we utilize, the side effects will recover or disappear once the treatment is finished. I'm saying as a general rule because that is not absolutely true always for every patient and for every side effect. So for example, some chemotherapies may produce tingling in hands and feet. Usually if you stop the treatment, that may disappear or may improve. There is some research in long-term side effects, especially I will say with PRRT, for example. We know that because there can be some damage to the bone marrow, there can be some long-term side effects that have been investigated and that we know they are low incidence, quite rare, and therefore if you put the balance between the risk and the benefit of receiving PRRT from that point of view, the treatment is worth administering. So I think we always take into account the risk of those long-term side effects. In general, the chances of someone having long-term side effects for the treatments we utilize, I will say, is rare. But they are very important and relevant in NETs because we know that these are slow-growing tumors. We know patients will get more than one treatment and they will live for a long time. So those side effects are also important, very, very relevant.
Absolutely. I think we have to finish this section now, Marianne, actually.
Maybe we can still shortly address one issue, the ethnic impact for example, for everolimus, the ethnic impact, that was one of the questions I feel very important. Who wants to, do you want to comment on that, Angela or Simona?
The ethnic impact.
Yeah. So I say my personal experience is that when I went to meetings and I worked a lot with everolimus, for example, for decades in many trials, and we always recommend in oncology one dose fits all. They all get the 10 milligram, but that may not be right for the Asian population. I had patients or physicians that were approaching me after meeting and said, oh, my patients are dying from that drug. And I think the sensitivity to everolimus is much higher in Asian population, and the dose may be much, much too high. I mean, it may be even too high in Western population. In fact, we do dose reduction in 60% of NET patients with everolimus, to give you one example from the targeted agents. And I think there is a lot of room for improvement, that we need to adjust the dose and maybe do drug monitoring, what is not common standard and maybe not everywhere available. But I think the dose needs to be adapted also according to ethnic origin. For example, everolimus is one of the examples.
I completely agree with you, Marianne. If you remember, some time ago, we were meeting during our meetings, and I was always looking at some talks and saying, wow, this drug, for example, I'm using the daily basis everolimus, for example, as well as all the other options of treatment, but just for the matter of example. So I was hearing that the people are taking, for example, everolimus without side effects, and I was coming back home to our center, and I was looking at my patients, and I was feeling so frustrated because in most of our patients, for example, I have to, or I was supposed to decrease the dosages, and in order to make the treatment not to be stopped, you know. And then I learned by myself, I usually do not start in my patients everolimus, but also other drugs, for example, at the maximal dosage that is, you know, recommended, or the regular dosage that is recommended. For example, with everolimus, I'm always starting it at the lower dosage, increasing it slowly, because of these side effects that we are seeing more than in other places, that, for example, in Europe or in other centers. And so I completely agree with you. There is much still to be researched on. It's not a, you know, a drug which is best at the same dosage for all the people all around the globe. So thank you for the question. Very important one.
Yeah,
my experience. So I will be very quick, Catherine. My practice is different. I do start on the full dose, but what we do is an early assessment 2 weeks after starting in case there is a need for a dose adjustment. There might be some ethnical differences, some, you know, differences in the metabolism of the drug. I'm not aware of any specific research, but definitely I'm sure there is something that could explain that. My practice is not like Simona's starting on a reduced dose. We start full dose, but there is an early assessment 2 weeks after to assess symptoms in case there is the need of a dose reduction because of toxicity.
No, thank you, Angela. And I think
ethnic question was very important, and I think there was a statement here that is very important from the audience that we can all take along with us. Should the clinic provide? That's not a question we will discuss.
I know, I was literally just about to say, or we could finish off on a great suggestion, because quality of life has got to be the most important factor here, and we haven't probably mentioned that enough, but carry on, Marianne. Yeah, absolutely.
Yeah, like the quality of life, that's right. That's probably you wanted to pick the same. Should the clinic look to provide a lead for patients around quality of life? A short discussion every quarter, half year is intimidating and does not get all the information out. Would some kind of questionnaire diary improve communication? I fully agree with you.
Yeah.
I think even ourselves being busy, seeing sometimes 10 patients in a row, we do not have the full time to really fully assess the symptoms, and some patients do not mention them. You really need to ask them, are the symptoms there, yes or no? And then others, they voluntarily say easily even minor symptoms. So I think we should have a more regular assessment, and that's a very great idea. And by this, I will give the word back to Casey. I would like to thank both of you, Angela and Simona, for this great presentation and discussion.
Thank you.
Yes, thank you both. So we better move on as we're a little bit over, but that's great because at least we're getting the discussion and the interaction, which is fantastic. So let's move on to part 3, entitled Patients as Partners in NEN Research, Key Focal Points from Clinical Research. What is it telling me, and are patient views being truly considered? And it's great that we have Enrique Grande from Spain and Anja Rinke from Germany. So thank you both, and the floor is yours.
Thank you so much, Catherine. It was a very exciting discussion before. So, well, let's go and let's talk about the research. Where are we now? What do we know? And what do we need to further investigate? Can we please go to the next slide, please? Okay, next one. My disclosures and the next one. So everything started, well, of how we are facing, how we are dealing, how we are treating our patients with metastatic neuroendocrine tumors. It started in 1907, at the beginning of the 20th century, with this guy, with a pathologist called Dr. Obendorfer, who was the first to describe what this was the carcinoid, so a kind of cells. Next one, please. It was in 1973 where Roger Guillemin was the first one to discover the receptors of somatostatins and the somatostatins, the protein, the ligand, which has a very important impact on the physiology of these tumors. This is the protein, this is the hormone that is making these tumors and these cells well working and proliferating. Next one, please. It was in 1972 where Charles Mortel, he was a clinical oncologist who developed the first randomized trial in this field and the first drug to be approved. It was streptozotocin in a chemotherapy agent, but now it is very fashion because it is becoming one reference standard of care again. So we are using more and more of this drug and we know how to use this drug. Next one, please. It was my colleague here, Dr. Anja Rinke, that today will talk after me, who did the first randomized modern trial in which it was shown for the first time that the somatostatin analogs, at this time octreotide, was able not only to control the symptoms because of the hormone release of these tumors, but at the same time it was able to control the tumor growth. So for the first time we were able to, well, to use other drugs than chemotherapy that were able to delay the growth of these tumors. Next one, please. Well, in the era of targeted therapies, and when I mean targeted therapies means, well, oral drugs that are controlling for the growth of the blood vessels that are supplying oxygen and nutrients to the tumor. It was our colleague Eric Raymond who did this trial in which one of these anti-angiogenic agents, sunitinib, was able to delay the growth of the tumors significantly, and it was the first to be approved in this field. And next one, please. After that, and at the same time, well, Dr. James Zhao led the 2 trials with everolimus that was Dr. Pavel, Marianne was discussing before. Everolimus is an mTOR inhibitor, an oral drug as well, which is controlling not only the tumor growth, but it is controlling also the metabolism of the tumor cells, of the neuroendocrine tumor cells. Everolimus has 2 indications, pancreatic neuroendocrine tumors and extrapancreatic neuroendocrine tumors, G1 and G2 tumors. Both sunitinib, the anti-angiogenic agents, and the mTOR inhibitors, everolimus, are approved for G1 and G2 tumors and are the 2 targeted therapies approved so far in this field. Next one, please. Well, Martin Kaplan was the lead investigators of the Clarinet trial. The other somatostatin analogs, lanreotide, was inducing and controlling the tumor growth for patients with midgut tumors and GI origin, from the gastrointestinal tract origin, and at the same time from pancreatic origins in patients with G1 and G2 tumors with a Ki67 index, so the proliferation index lower than 10%. So it was another step forward in this field. Next one, please. The radionucleotides were coming to the field of neuroendocrine tumors in 2017 with the NETTER-1 trial led by Dr. Jonathan Strasberg, in which for the first time in a randomized trial, well, lutetium dotatate, Lutathera, the radionucleotide, was showing superiority in terms of delaying the tumor growth versus high doses of octreotide. So I think statistically very clearly significant, but at the same time clinically significant, the use of radionucleotides were coming to the field of neuroendocrine tumors. And finally, next one, please. Dr. Matthew Kulke led the Telestar trial in which, well, telotristat, serotonin inhibitor, a serotonin synthesis inhibitor, was approved to try to control the hormone release for those patients with a carcinoid syndrome that unfortunately is not well controlled with the standard somatostatin analogs. So this is the current landscape. Next one, please. This is the current picture that we have in the field of how we are treating our patients with metastatic neuroendocrine tumors. Of course, we need to highlight that we need a multidisciplinary management, including pathologists, radiologists, interventional radiologists, surgeons, endocrinologists, GI specialists, oncologists, radiation oncologists, nursing, palliative care colleagues. So there is a need, a huge need to, well, to face the treatment of our patients into a multidisciplinary environment. This is critical in daily practice. And next one, please. And this is my last slide. We need to keep on investigating in this field. We need to keep on going. We need to know further. We need to do more things. Unfortunately, we still cannot say that we can cure patients with metastatic neuroendocrine tumors so far. We need to have better and more drugs to offer to our patients in order to do this sequencing approach. If one drug is not working, well, let's go to the next one. If this is not working, let's go to the next one, trying to impact in both the global overall survival of our patient and at the same time, the quality of life. Unfortunately, we also need to get better in terms of finding a reliable biomarker. What is a biomarker? A biomarker is a measurement of anything in the blood or anything in the characteristics of the tumor that is helping us to select, to identify which is the best drug for each of the patients that we are treating. We also need to improve in the initial diagnosis because today it is taking too long. It is considered that the initial diagnosis is delayed for about in between 5 to 7 years in the majority of the patients. We need to add, we need to improve in these figures. We need to improve also in the access to experienced physicians, techniques, and new drugs that can be better. And of course, we need to get an easier access to our patients to clinical trials in order to, well, to get these drugs, more drugs and better drugs in the daily practice. Next one, please. Thank you so much to all of you for your attention. And I think Anja.
Yes, thank you. I'm very happy to be involved today, and I feel honored by being mentioned in your milestone presentation, Enrique. Thanks for that also. So my focus now is on the role of patient in research. Next slide, please. My disclosures. Next slide, please. Of course, obviously, all the drugs mentioned just a few seconds ago by Enrique were approved because we had positive results of clinical trials. So it's evident that we can't do clinical trials without patients, of course, but sometimes if I ask a patient whether he or she would like to be included into a clinical trial, there are some concerns regarding the uncertain efficacy or possibly new side effects. So on the other hand, I think a clinical trial may be a chance to get access to a drug that is new in the field or that's not already approved. And regarding side effects, you can be quite sure that there's a close monitoring within a clinical trial. On the other hand, of course, close monitoring means you have to go for every visit to the center, which means it's time consuming. If you decide you maybe include it into a clinical trial and you feel during the trial it's too strenuous, there are too many visits, or you are not happy with the drug within the trial, you're allowed to terminate the trial whenever you want without giving us reasons for that. So I think, of course, you have to have your personal pros and cons and decide on it. But I hope that we can work together, collaborate to get new clinical trials, positive trials, and to get new drug approvals and more possibilities to treat this disease. Next slide, please. Now, if we try to plan clinical trials, I think we also should include your patients and patient organizations, because of course clinical trials is very expensive to conduct and also time consuming. So we can't run many clinical trials in a rare tumor disease at the same time. So we have to set our priorities. And I think that this would be discussed with you. Which is the trial that we really urgently need? Should we focus on new drugs, as I said before, in metastatic disease? And if so, should we go for pancreatic NET patients or small bowel disease, or for lung NET patients, or rather for neuroendocrine tumor carcinoma patients? So, and I think we should not mix all the entities to get clear answers. Or should we rather look for best sequence of treatments that are already available? Should we try to focus to get a bigger rate of patients to be possibly cured by surgery via pre-operatively treatment, so-called neoadjuvant strategies, or with adding after an operation adjuvant treatment? Or should we focus on diagnostic tools, or better on management of side effects, a topic we already heard a lot about, or optimal dosing? So I think it's all well taken aims, but we have to discuss which clinical trials are most urgently needed. Next slide, please. And for planning the clinical trials, always also very important how to measure success. And this parameter, which in first line measures success, is so-called the primary endpoint. And probably for you as a patient, the most relevant questions regarding treatments is, do I live longer, which means overall survival, or do I live better, which means quality of life? But these both endpoints are hard to assess, to be honest, because as a prognosis in well-differentiated neuroendocrine tumor patients is good, to create a trial focusing on overall survival would mean you would really have a huge cohort to be included, and a trial running for decades, and also had to be balanced for all treatments coming after the clinical trial. So it's not feasible to address overall survival as primary endpoint. So as a surrogate, often the so-called progression-free survival is taken. Progression-free survival means that from the start of the treatment within the trial until a progression according to radiological criteria occurs is measured this time. But of course, we should discuss whether combined endpoints, also including patient-reported outcome measures like quality of life questionnaires, should be included to create better trials, so that may matter more to you. Next slide, please. What about basic research, or so-called translational research? The idea of translational research is that we come from the patient, go to the lab, and with more information go to the patient again. So for example, we can take blood samples or tumor tissue, and this is investigated in the lab. Maybe in the blood specific markers are measured, or circulating tumor cells, or so-called microRNA, or the tumor mutations are analyzed, or other genetic alterations that may be targeted. Or we can try to grow cell lines, which is it's not easy in this disease, or organoids, and test them, which drug could be helpful. And with this extra information, we can come back to the patient and have so-called predictive markers, so an idea which drug may be the best one, or an additional prognostic information. And this also made the basis for so-called personalized medicine. And if there's a trial available for a patient with a given molecular marker that has been identified, the patient may be included in basket trials where this specific marker is going to be targeted. Next slide, please. So to sum up, I think the patients and physicians have to collaborate really for successful research, and we won't make progress if we don't collaborate in this. And of course, we won't get new drug approvals without clinical trials. But I think patient and patient organizations should also be involved in establishing priorities and defining the most relevant outcome parameter. And I think translational research is important to develop personalized approaches, and we should rather concentrate on support biomarker-driven trials than giving a drug to all patients, whether they have a molecular marker or not. And that's all. Thanks a lot for your attention. And I think Enrique and I am happy to try to answer the questions.
Thank you so much. Casey, you need to unmute yourself.
Should know that by now, shouldn't I? Perfect. Thank you so much, guys. We have got a few questions that have come in, so we'll just fire those at you, I think, if that's all right. There was a question about trials in NEC and where are we, and are there any, and are there going to be more?
Yeah, of course. We have, unfortunately, not large trials, but very interesting trials. We saw recently how we can combine chemotherapy, the current standard of care, plus immunotherapy. Immunotherapy, you know that this is one of the most sexy drugs that we have in the field of metastatic tumors. And everybody wants to be treated with immunotherapy. Immunotherapy is like a kind of vaccine in which we are trying to make the immune system of the patients make it to learn how to deal with the tumor. So we are not targeting directly the tumor, we are targeting the immune cells, trying to activate it and trying to make it work against the tumor. Initial data are very exciting, but we still are a little bit far for the approval of this kind of agents. We are combining, or we are testing different chemotherapy schemes in this field. We are on the way. We are on the way to improve our weapons here.
Oh, that's very positive. Thank you.
There are other questions here from the audience.
Yeah.
And one of those is, do you see active patient involvement along the research continuum as an essential prerequisite for carrying out meaningful and practice-changing research in NENs? I mean, patients as partners from setting the research agenda to defining endpoints.
Anja, this is for you.
Okay, thank you. Yeah, I think that's my idea how things should develop. I think we're quite a bit away from this, but I think, I mean, if a company has a drug and there's a rationale to be tested for neuroendocrine tumors, and then we give the money for doing the trial, we're probably happy and won't have too much influence regarding primary endpoint or the exact planning of the trial. But for other trials where we ask for public money, I think we should really better, in the future, we should really involve patients more than it's done so far, because the perspective of a doctor may be another one than that one of the patients, and we have to focus. We can't do too many trials at the same time. So I think the idea really is to go for more patient involvement in planning and conducting trials. Yes, I think that's the way we should collaborate in future.
Yeah, absolutely. The gold standard, I think. It's certainly something that we would love to see more of, especially in this field. I think this is around cancer vaccines, a question about they're being studied in diverse types of cancer like melanoma, lung cancer, etc. I don't know whether that's alluding to the immunotherapy again, but it said, is it something that may be studied in NETs soon?
Hopefully, yes, but I'm not completely sure, neuroendocrine tumors are the best solid malignancies in which well, vaccines are gonna work, because vaccines normally they need a target, they need something to add against, they need to make the immune system to work against something, you know. And the major driver that we have is the somatostatin receptor. And in somatostatin receptor, well, it's not only focus or no, it's not only present in the neuroendocrine cells, but you can find it in other cells, including the endothelial cells, the cells that are forming the blood vessels. So I'm afraid it's going to be hard, well, to develop a vaccine against neuroendocrine tumors. But I wouldn't look at the other side. I mean, we need to advance in this field, and why not to develop a vaccine for our patients with neuroendocrine tumors?
Yeah, it'd be nice to be a bit more equal with some of the other cancer types. I can totally understand the frustration when you see developments in some of the more, I suppose, common cancers compared to ours. You know, I think it's difficult, and I think certainly in some of the more rare neoplasms as well. I mean, what kind of work is in the pipeline for some of the more rare neuroendocrines? Obviously, we hear a bit about the JetNet and lung, I guess, most commonly, but you know, is the work happening in the pipeline for other neuroendocrines, paragangliomas and ovarian, gynae tumors, etc.?
Well, the diagnosis, you know, the more advanced techniques that we have in the nuclear medicine field, you know, probably will help us to try to identify patients for new drugs that can target new radionucleotides that can target these rare malignancies. Unfortunately, the development and the knowledge that we have about the molecular biology is not really helping us a lot. We don't really know much about the biology that we can work on different targets or new targets in this field. We have a recent new drug, sunitinib, the one that is approved in the neuroendocrine field, that has offered for very good data in pheochromocytomas, paragangliomas recently, just 1 month ago, a couple of months ago. So we are improving, but not as much fast as we wish in this field. There is a new family of drugs, the antibody drug conjugates, which are now very active in other metastatic tumors and are coming to the field of neuroendocrine tumors. Well, let's see what can we expect from these new drugs. But unfortunately, in the short term, we don't have too many options that are coming shortly.
Okay, well, it's honest.
There's also a question on clinical trials in NEC. Maybe you can highlight which of the current trials are ongoing and maybe where patients can have information how to access these trials.
One of the challenges that we have, because we have a very well established and standard option in the first line setting, and this is based on platinum-based chemotherapy. But for those patients that are unfortunately, platinum-based chemotherapy are not working, are failing, we don't have any good options to offer right now. So there are a couple of trials in this second line setting, in the platinum refractory setting, randomized trials that, we hope that they are bringing some lights in this field. We have also the challenge to, for those patients with well-differentiated tumors, but high proliferation index, so what we call the neuroendocrine tumor G3, well, probably the targeted therapies or radionucleotides can have some activity there, and there are some trials trying to see if these drugs are working for this particular subset of patients with aggressive tumors, but not that much aggressive than the carcinomas, the neuroendocrine carcinomas. Immunotherapy wants to reach this field, and immunotherapy makes sense for carcinomas because the more mutations the tumor have, the more antigens the tumor is releasing, and this antigen serves as a food for the neuroendocrine, for the immune system of the patient to attack the tumor. So this is why we are trying to control these aggressive diseases.
So the combination of chemotherapy plus immunotherapy is ongoing in that field. But also in Spain, you're doing a trial with TKIs, cabozantinib, in combination with immunotherapy. That also includes a NEC cohort.
We are combining chemotherapy plus immunotherapy. We are combining targeted therapies plus immunotherapy, and we are combining 2 immunotherapies together. So everything that we can do with immunotherapy, we are doing that.
Very thank you. We are actually pretty much run out of time, but I think there was a comment here which I think it's important that we share, that says, as patients we keep hearing that more research and clinical trials are needed, but who or which body exactly is taking the lead for this? Who or wants to be accountable so that we are not saying the same thing in 5 years' time? Which I think is a great question, not probably the easiest to answer, but
yeah, that's very important. I agree. And I think the patient involvement is already different in different countries. There are some patients that had already been involved in clinical trials. One is a composed study where patients were also consulted. That is in NET-G3 and NET-G2, very highly proliferating NET-G2, where PRT is compared to the other treatments that Enrique outlined, that is either chemotherapy or one of the targeted agents. So patients were consulted also in other clinical trials, what is really feasible for the patient, what is acceptable in maybe new drug development that may be associated with serious side effects. And also Australia is a very good example where patient or support groups were involved in gathering even funding to make a study fly, like a combination of PRT plus chemotherapy, the control NET study. And MIT in Boston, there are patient and support groups are involved to donate tissue to advertise, because research progress can only happen if we learn from the preclinical data, as Anja and Enrique outlined. We need to understand better tissue and circulating markers in the blood that we can't well define right now. But maybe we will understand from these patient-based biological data who is susceptible more to the one or the other treatment, because we understood we can't run all these trials in parallel. We need to be more focused. We need to better pre-select our patients, not to expose you to unnecessary toxicity that you would not need to tolerate. That's our duty to move that forward. And not every patient is the same. Some are already overwhelmed by their own history and they could not be advocates, but there are others that have partners or themselves have the capability by their education or the personal wish to be involved. And I think the best is to reach out to your center, to your NET center, and ask, how can I support it? Or to the support groups and to INCA, how can we get involved? This is why we are here, to find strategies, how to enhance our collaborative efforts. And that's why I'm very grateful that you brought up that question. But we need to have a strategic plan that we also should put at the European level to implement that at an earlier and very clear stage from the upper level and not only from the center side. And then this is depending very much on individuals, how active and enthusiastic they are to move something forward. And that requires a lot of negotiations with companies and so on. But I think everybody is open and willing to improve this research. So there should be ways, but we should define those. And I also would like to take the opportunity to thank everyone who has been involved in clinical trials. I had performed so many clinical trials over the last 20 years. And I must say, there's so much commitment, and without you patients, this would not have been feasible that we have registration of these compounds. And sometimes and often you do not even have a benefit. You just did this for the broader community that we learned from these trials, particularly comparative trials. You could have access to PRT or everolimus. It could be your own choice or the physician's choice and your choice. But your willingness to participate in these trials that just gather knowledge for the broader community and to make these treatments more stratified in the future, I'm extremely grateful for this.
Yeah, absolutely. Great comment. And, you know, maybe there's a role to be played in a world forum really for, you know, a group that come together for accountability for research into neuroendocrine, a consortium, I guess, of researchers that can maybe, as you say, strategically plan what needs to be done next.
That was a very important topic, Anja and Enrique. Thank you so much for preparing and presenting here. Much appreciated.
Thank you.
Welcome. Thank you.
Thank you.
So we are moving to part 4. That is also a very important issue. And I think we can even pick up some of the remaining questions that we didn't cover from the beginning. Nutrition in neuroendocrine neoplasms. And so we have several speakers in that setting here in this session. Welcome to all of you again, Wanda and Sally and Mette and else. So I would like to give the word first to Sally.
Hello, thank you very much for inviting me to take part in this and to tell my NET story. Could I have my first slide, please? Yeah, I'll give you a whistle-stop tour of my NET history, which goes back to around about 2007, 2008, when I spent quite a lot of time in and out of a GP surgery with increasing symptoms of mainly diarrhea and abdominal pain. No tests came back that were positive, but eventually in January 2009, I needed emergency surgery because a tumor blocked a blood vessel in my abdomen. I went into that surgery with a full set of digestive bits, and I came out with a short bowel, a stoma, and TPN, a feeding tube into my chest. I came out also with a diagnosis of stage 4, i.e. spreading tumours throughout my body cavity, and which were grade 1. So they were very slow growing, sluggish tumours. Later that year, in September 2009, the ileostomy was reversed and the TPN was stopped. And I became medically stable. I was given octreotide and SSA, but in fact, my quality of life didn't really change very much. And I had to retire from work early, rather reluctantly. That poor quality of life carried on until around about 2015, when I was, for the first time, treated by a NET specialist. And then I had a really sharp upturn in quality of life. That was quite a revolution for me. Then the NET specialist, he was a one-man person down here in Wales, and there was no service here at that time. So I was referred to London, to the Royal Free Centre of Excellence. And then my tumours stayed stable for about 10 years until 2019, when there was some evidence of progression. And I had 4 rounds of PRRT in 2020 and 21, which seemed to have done the trick, and I am now stable again. Could I have the next slide, please? So what I'd like to look at now is that period of time when I was medically stable, but had poor quality of life. So I was still getting diarrhea, pain, and I had slow weight loss. And at that time, several assumptions were made about me. It was assumed that I was lactose intolerant, that I had too many bacteria in the gut, and that the after effects of surgery were causing pain. I don't think that any of these were actually correct. I was taking up to 16 loperamide a day, because that's what you do for diarrhea, don't you? I had access to creon, but I wasn't told what the right dose was, and I didn't know how to calculate it. Then off my own bat, I took some lactase tablets and heard about this stuff called cholestyramine, which I got from the GP. So it was very hit and miss. I was advised to go on to a high protein, low output diet, which to me meant I ate rather a lot of meat, but no fruit and vegetables. I gave up milk. I tried to cut down to a very low fat diet. And I ended up on a rather unpleasant diet where I didn't enjoy food. It meant that I couldn't really go out with my friends. I couldn't travel because I couldn't eat out. I still had a slow weight loss, and I was continually tired. But then came the revolution, and once I was in the hands of somebody who knew how to treat NETs correctly, my quality of life really took a sharp upturn. And it was confirmed that part of the reason for the diarrhea was bile salt malabsorption. I was put on the right dose of Creon, introduced to something called Colisavalam, which worked very well for me, and was given varied supplements. Now I have a really good quality of life. I have a varied diet. I can do most of the things that I want to do. And I have to say, I'm extremely grateful to the team who treat me and give me a good lifestyle. So that's my story. Thank you very much for listening.
Thank you so much for sharing your personal history. I think now we can open the panel discussion with everyone. Or else we'll first give our presentation.
Yes, I think because of the time we decided to give our presentations and then in the end have some discussion.
Welcome, Else. Please.
Yes, thank you very much. Well, as a surgeon, I heard the story of Sally, and I can just add something to that from a surgical standpoint. I will not go into the details of the feeding and the nutrition at this point. If I can have my next slide. And the next one, please. This is my only slide. And what the problem is that a lot of patients with small bowel NET, or maybe also other NET, are going to be in trouble, maybe in a hospital where they are not very well known with NET disease. And if you can imagine how the abdomen of Sally would have looked like when she came in for emergency surgery, it would have been a devastating look for a surgeon with a lot of liver metastases probably, and a lot of lymph nodes and bowel that was not looking very nice, maybe a little bit ischemic or turned around those lymph nodes, and a lot of problems. And then what I try to teach all the surgeons I know who are going to encounter this problem is to be as saving as you can be. So to save as much as you can, because you cannot remove all tumor, but you should solve the problem. And what you heard from Sally is that she ended up with a small bowel or short bowel syndrome. So she had lost quite a lot of bowel from the primary surgery. And I think now we have to really educate all the surgeons to be as sparing, as saving as they can be. And that will probably not make sure that they don't need a second operation sometimes, because you want to improve on the first one. But the emergency surgery is always the worst to do. And it's a pity that we didn't understand the problem earlier. But when you come in this condition, I think surgeons should be aware to be as saving as they can. And a lot of the nutritional problems after surgery are, of course, not only related to the surgery, but they are related to the tumor syndrome. So if a surgeon comes back with the pathology report and it says something like neuroendocrine, they should be trained to really get into help from NET specialists. And I think here from the story from Sally, you can hear that that took quite a while. And that's always, on one hand, it gives the next doctor some insight in what didn't work. So you also give them some experience. But on the other hand, it took too long, I think, before someone really knew what the problem was. So 2 things for the surgeons, which I'm always training them to do, is first be as saving as you can, because you don't know what the disease is going to behave like. And we have a lot of other treatment options. And the second thing is, once you've seen the pathology and you know it's NET, refer them to a center of excellence. So that's my addition to this talk. And I give the word to the next one.
Good afternoon, everyone. It's a pleasure to be part of this great initiative on World Net Cancer Day. So please, next slide, please. These are my disclosure slides. Next slide, please. Hereby, I would like to present some important issues for patients and NET nurse specialists or nurses who are taking care of patients with NET disease. As just excellent shown by Shelley, the case of NET patients can be very complicated. And although specific knowledge is essential, unfortunately, it's not for every nurse to have such sufficient knowledge of all the problems that an NET patient can have. But we can learn a lot from these case studies. But as a nurse, you can assure that the right questions are asked to the patients. So this can help to eventually make sure that you can make the correct diagnosis. So make sure you speak the same language. For example, what does diarrhea mean? For some people, this means mushy stools once a day, or for others, it can be watery stools 10 times a day. And it's important to speak about what does it look like, how often per day, what's the color, the smell of the stickiness, and how does the patient, for example, experience flushes? Are they dry or are they sweaty? And what does little intake mean? Not every patient is eating the same. And you can use simple tools like this one showing at the right side. And you can also use them as a patient to be more clear to your caregivers. Next slide, please. My advice to the patients is make your complaints clearly and mention anything that you think that makes sense, because we need your information. Next slide, please. So talking about bowel movements, it's not strange, but it's necessary. And I often see that patients feel burdened to talk about these subjects, but we need your symptoms and complaints to help you further. Next slide, please. If a patient comes to you with these problems, like Sally just told about, it's important to involve a dietitian in the treatment team on time for appropriate interventions. And that's really important. And Mette will tell you some more about this later. Next slide, please. And treatment with medication or supplements can also have side effects. And the best attainable quality of life is important, as mentioned before. That should always be point one in the discussion. What will leave you with the most quality of life? It's important to achieve this. And next slide. So therefore, follow-up and accessible possibility for contact is important. And as a nurse, with often more accessibility, contact possible, you can play a major role in this. Please, as a patient, always ask for if there's a nurse available for you to talk to or to talk to in between your other appointments. And this is important because, next slide, like checking vitamin values, because this case is about nutrition. I will only talk about these subjects here, but you can also ask your nurse for other questions for sure. But also interactions with other medication, like Selimet, Colesevelam, can have interaction with other drugs like verapamil or clemide or oral contraceptives, or even levothyroxine. So please mention that what you are using already and talk about if they have interactions with each other. Another important thing is to speak about unwanted effects of the treatments. For example, triglycerides concentration have an increasing effect of using Colesevelam, sometimes in high doses, and that's especially patients with type 2 diabetes or already have high doses of triglycerides. So these are important things as well. And I think, well, to talk about these subjects, you can help you can help yourself and you can help your caregiver to make the right decisions in making the right diagnosis. So please, I will give the floor to the next speaker, that Mette Borre, who will talk about dietitians.
Thank you for this nice webinar. It's a pleasure to be a part of it. My name is Mette Borre, and I'm a dietitian at the Center of Excellence in Aarhus in Denmark, and we have a great teamwork at my department, I think. Next slide, please. I have no disclosures. And next slide, please. The goals of nutrition in NET, specific for Sally, is that we have to minimize her weight loss and to improve her level of energy and improve her nutritional status. I think something that is important for us caregivers is that we should try to weigh our patients, put our patients on a weight when they come. And we should optimize their quality of life by speaking nutrition and diarrhea with these patients. I think we have to be progressive in this area. My role as a dietitian is, together with the team, to improve her sequela after treatment. We know that the short bowel and the medication will give her loss of nutrients in her stools. And in fact, the surgery and the neuroendocrine tumor will give her loss of appetite. So it's a bad situation. You have loss of nutrients and you have a low appetite. That's not a good combination. The surgery, you have heard, gives the bile acid malabsorption and it gives the diarrhea. And it's very important that you handle this diarrhea with bile acid secretions. Sometimes it's a good idea to moderate or to lower the fat content of the diet, because it could be urgency in defecation if you have a diet with a high fat content. On the other hand, it's important that you don't lower the diet, the fat content of the diet too much, because then you will have a great weight loss. The somatostatin analog, we have heard earlier that it gives an exocrine pancreatic insufficiency. And I think we don't see that, or we see that quite often, but we're not aware of this. It's important to supply with pancreatic enzymes to all meals, that Sally told us, and the doctor told us as well. And I would, together with the patient, I would calculate the fat content in the different meals and tell that you should have a small amount of enzymes for a snack. You shouldn't have enzymes for an apple or an orange. So I will go through the diet together with the patient. We should, of course, examine, monitor, and treat vitamin deficiency, especially the fat-soluble vitamins, but as well the B12 because of the surgery. The water-soluble vitamins are, of course, important as well. I wouldn't give the vitamins through diet. I would supply with a supplement. Next slide, please. I know that there's not an access for a dietitian at all departments, but then you have at least to give a booklet, or that the nurse should talk with the patient about the diet. As a dietitian, it's very important that you do not guess. It's together with the team, you should trust the examined diagnosis and go through with the journals, the fields, to see what is the problem with this patient, because guessing that it's lactose intolerance or the fiber content, it is wrong. In Sally's case, I would ask for a food and symptom diary, and I would ask Sally, what are you eating? When do you have symptoms? Is it when you have fiber or fat, or what is the problem? For Sally's case, it was the spicy food as well. It would give me the best possibility to make an individual dietary treatment based on diagnosis, actual food intake, and preferences and resources. The last point is very important, because you shouldn't stand the whole day in a kitchen preparing different dishes, and it's very important that we talk about food instead of protein, because we enjoy food together with our family and friends, and you don't eat protein, you eat food. So that's very important as well. Regarding the weight loss and energy level, specific for all kinds of neuroendocrine tumor, I think it's important that we know that it's important that the protein content is high. But specific for Sally, because of the short bowel, we have to increase the protein content of the diet even more, 1.5 up to 0 per kilo per day, but that's specific for Sally and not for all patients with neuroendocrine tumor. And the importance of supplying with supplements, vitamins and minerals is important as well. If a patient have a weight loss, I would very often use all nutritional supplements that you can buy at the pharmacy with a high protein content. The energy level in Sally's case has to be high, and that's important because of the short bowel. I would give Sally at least 40 to 50 calories per kilo per day, but that would not be the same for all patients with neuroendocrine tumor. Giving that much energy at the same time, looking that the fat content shouldn't be too high, that's difficult. So I think it's very important that if you have a case like Sally's, that you have to include a dietitian in to give her a proper, a good treatment. We have talked about the enzymes, and I would give enzymes for all meal to help absorption of fat and soluble vitamins. The bile acid malabsorptions, I think that the first choice is to supply with bile acid sequestrants, but at my department, we very often see these patients and we moderate or give a personalized low-fat diet, and at least we try to inform the patients that if they go for Christmas for having a meal with a very fat high content, it could be urgency of defecation. So we have to tell these patients that a moderate low-fat diet could be important, but that's not, it's a very difficult area, this. First of all, quality of life. You relieve the symptoms of diarrhea, you give more energy, but no one likes restrictive diet. So one of a very important points is that you should speak with the patient about resources and food preferences. Yeah, thank you.
Thank you all for your nice presentations. It was very important topic. We still have time to discuss.
Yeah, absolutely. Thanks everybody. We have had a few questions that have come in, but I just wanted to ask one question to you, Sally, which isn't specifically related to the nutrition, but thinking of the quality of life that you experienced in about 5 years when it was incredibly low quality of life, and you say it was a really poor quality of life. I mean, that must have been really challenging. And I just wondered, you know, I know you were referred to a centre or to a doctor who had some expertise, but did you have any sort of trust issues with, you know, the healthcare system, etc., after you were feeling just so awful for 5 years?
In the beginning, yes. It was difficult. In the very beginning, I trusted the NHS implicitly, and I thought, I'm going to leave it to the experts. It was gradually borne in on me over the next few years that I wasn't getting what I needed. And it was a gradual process. It was almost an educational process. And it was borne in on me and a group of other patients in the same area, because we were all in touch with each other. And yes, to a certain extent, we lost some confidence in the health system. But then we realized that we weren't actually being treated by the right people. And once we came into contact with the right people, then our lives just changed. And so the big message to me for patients is make sure that you are treated at a specialist centre. NETs are very complicated, as you can see from the whole what we've been talking about for the past hour or so. It's not a simple situation. Everybody's different, and you do need individual attention from a network of experts. It's not just one. The input needs to come from a good number of people. Once you've got that, then yes, you can have confidence as a patient. And now I feel very much part of the team. I'm not having something done to me. I'm part of all the decisions. And so, yes, now my confidence has been restored and I'm really pleased with my situation. I feel that it's as good as it possibly could be given my physical situation.
Thank you, Sally. That was a great answer. Thank you.
Very essential message to the audience that if patients are suffering, they need to head to another center that is specialized on nutrition. And I agree with you, frequently that is neglected or taken seriously too late. We also had a question here related to the gallbladder removal. I would like to give that to Els because a patient here is reporting that there was not a properly discussion post-surgery in relation to digestion and absorbing food, no gallbladder contribution to digestion issues. And the patient found that out later. Can you address that? What is the impact of the gallbladder removal? And should we always remove it? Is it still necessary? Is it standard procedure?
For gallbladder removal, if you look at the normal population where the gallbladder is removed because of gallstones, there's no impact on the diet. So there's no impact at all. So therefore, it is very difficult to anticipate that for NET patients, a gallbladder removal would have impact on their diet. I don't think so, but I don't think there are a lot of studies supporting this. What we used to do is thinking that the octreotide or the somatostatin analogs, they have an effect on the gallbladder. They have an effect on the formation of gallstones, and they have an effect on the flow of the bile itself. So when you are on somatostatin analogs, there is an increased risk of developing gallstones. And in earlier days, in the guidelines, it was said that you should remove a gallbladder if you were going to operate on NET patients. But then again, that's not completely a one-to-one comparison. So now we say we want to be restrictive and we don't remove the gallbladder always. We discuss this with the patients. If they already have some gallstones and they are going to be on somatostatin analogs in the future for longer periods, then it might be a wise decision to remove the gallbladder. But I don't think you want to remove the gallbladder because of diet issues. That's never been supported by any research, I think. So we discuss it if the patient has gallstones, then we discuss if the gallbladder is going to be removed. But of course, in emergency situations, you're never going to remove the gallbladder if you haven't talked about it beforehand. No. I hope this is the answer someone was looking for.
Yeah, thank you, Elisabeth. It's a very important topic. And maybe a final question before I give the word to Casey, because we are unfortunately already coming to the end. There was also a question related to the relation between Whipple procedure and somatostatin side effects. Maybe Wanda and Mette, can you comment on that? If you see more side effects on SSA, if a patient had undergone Whipple procedure.
Who is going to? I think the Whipple procedure is a very large operation, and it would imply big issues in nutrition. It's a very difficult issue in nutrition because of the removal of the part of the pancreas, and you make what we call it, the bowel smaller and so on. So these patients would lose weight, and yes, so nutrition is important in these patients, I think. But
yeah, I think nutrition is really important always in these big operations.
Oh yes.
But I do also think it's good to have your team focused on what the problem is post-surgery, because sometimes a patient can easily have somatostatin analogs without complaints, but sometimes these fatty stools are coming way after using somatostatin analogs, so they couldn't and sometimes this is related to the surgery. So you have to find out what's the problem. But in either case, I do think you will end up with using pancreatic enzymes anyhow. But the timing for that is really crucial. So it's important to stay in touch with your patients about their complaints and to see when it's the good time to interact these pancreatic enzymes. But I have the experience that most of the patients that have Whipple procedures need to use pancreatic enzymes anyhow.
Oh, yes, always, yes.
But there, I want to connect as well, because there it's always important that also your NET specialist is involved in the HPB unit where the pancreatic surgeons are, because a lot of the problems after Whipple can be recognized a little bit better by pancreatic surgeons maybe and the pancreatic team than the NET team, because the experience for PNET will always be lower than for the pancreatic NET. So you have to combine expertise. That's always difficult.
Sure.
Also to be, you cannot be selectively involved in a NET center. It's always a center with a lot of arms going to the pancreatic unit, going to the colorectal unit to be sure that you have the right information. And the patients don't have to move. They have their NET specialist, but the specialists have to move between those specialists to be always well informed.
But I do think we need to discuss these topics more, because I do think that most of the topics are about surgery or not, or what kind of treatment or not, but not very much spoken about the using enzymes and dietitian stuff. So I do think we can make progress on that.
Yes, I agree. Yeah.
Mette?
I just want to supply that as a dietitian, it's a lonely job because there's only a few dietitians working with neuroendocrine tumor, but I enjoy very much to collaborate with some dietitians from Holland, Australia, UK, and we are going, in fact, we're looking through the evidence regarding nutrition, and we are making some guidelines regarding this. And and it's wonderful to have this group of enthusiasm dietitian working with the same area. So just to supply the discussion.
Yeah, I had a look through those, Mette, about 200 pages worth, wasn't it?
Yes.
That's small.
Impressive, but very,
impressive.
very good. That
We have to understand them.
Very good that you're working on that. That's really essential. It can make a big difference to the patient's quality of life.
We hope so.
That's our duty to improve that. It's a very important message from all of you. And unfortunately, there's not so much time left. I would love to continue with this discussion. There's so many open questions remaining, but I would like to give the words now to Casey before closing this webinar.
Oh, thank you, Marianne. Thanks to you, Marianne, for being my co-host. Always a great pleasure. But a huge thanks to the faculty for providing their presentations and for being here. And also a huge thanks to all of you who attended today. I really do hope that you found this a useful event. I really hope this is one of many. There are a huge amount of topics that we need to discuss, I know, but obviously we only have a certain amount of time, but I'm hoping that we can discuss future topics in future webinars. And as I said at the beginning, we will answer all of the questions that you've posted, and I assume we will provide some sort of link to the answers in a few days' time, or in a week or so's time, when everyone's got round to answering them. So I promise they will be answered. So I think just from me, I think just as a little recap, really, communication has been a key message throughout all of this, and I think we need to remain focused on open and clear communication. I think we really do need to continue recognizing patients as the partners they are in their care, and keep conversations very open, I think, about and constant about quality of life, and the best ways that we can assess that with the input of the patient community. There's obviously a need for a clear global research strategy, and I guess continued and increased collaborations amongst everybody who's affected by neuroendocrine cancer, and also all of those who are working within this disease area as well. So a huge thanks obviously to ENETS for this collaborative event, and thank you. I think it was a really positive event.
Thank you so much, Casey, for co-moderating. I was really delighted to share this event with you, and it was inspiring as always when we have these collaborative events. And I hope very much that we will continue down that road. I would like to thank all the speakers from today, and of course also Theodora from the INCA office, who was also heavily involved in constructing the program, always has great ideas and is closely working with other collaborative groups, and of course with Casey. I would like to thank the ENETS office who set up this meeting, particularly Regine, Leah and Uli, and also our technical partners, Marcus and Manuel, who were responsible for today's meeting. I already mentioned earlier the education group that is represented by Christophe Panakis, but also Eric Baudin, who had been involved in the content. I would like to thank all participants for all who actively contributed to this meeting, for all your questions and being in touch and interaction with us. That was really great. And we would like to ask you again to fill in the questionnaire that we can improve for future meetings. And there will be also a video available after today's that you can download, because we had a lot of information here and you may like to look back and listen to one of the talks again. So there is an opportunity in a couple of days. Finally, I would not like to close without announcing our next events. On the last slide, please. Next slide. Yes, just an overview on Save the Date on the annual conferences. Somehow it doesn't move forward, but it's just to announce our next annual postgraduate course that will be a virtual event on the 19th of February, and then we will have the first WorldNet Forum that will be a scientific meeting as a hybrid event on the 8th to 9th March in Barcelona. And finally, on the 10th to 11th March, we will have our ENETS meeting. And these are great opportunities to interact again, either virtually or in presence. We hope to see you all soon again in real life, hopefully. I wish you well until then, and good health. All the best, and thank you once again for joining this event.
Thank you. Thanks, Marianne. Bye-bye.
Bye-bye.